Bismillah ar-Rahman ar-Rahim. I'm Professor Manal al-Mahdi, Professor of Pathology. We will start the diseases of respiratory tract. This is an overview on diseases of respiratory tract. We will start by the upper respiratory tract diseases, including allergic rhinitis, nasal polyp, diphtheria, tonsillitis, and laryngeal nodule. Then we will move to the tumors of the upper respiratory tract, like laryngeal squamous cell papilloma, squamous cell carcinoma, and nasopharyngeal carcinoma. We will discuss in details in other lecture the obstructive and restrictive lung diseases and pulmonary infection. Also, we will take the different lung tumors like hamartoma, carcinoid, squamous cell carcinoma, adenocarcinoma, small and large cell carcinoma. And also we will take the different vascular diseases like pulmonary embolism and pulmonary hypertension. In another lecture, we will take atelectasis or collapse and respiratory distress syndrome, either adult or neonatal respiratory distress syndrome. Also, we will describe the pleural diseases and pleural tumors. In this lecture, we will discuss the different clinical picture and pathologic features of each of the following lesions: rhinitis, nasal polyp, tonsillitis, diphtheria, nasopharyngeal carcinoma, different laryngeal lesions like laryngeal nodule, laryngeal papillomas, laryngeal squamous cell carcinoma. The main function of the respiratory system is to exchange carbon dioxide for oxygen. We have two portions of the respiratory system: conducting portion and respiratory portion. The conducting portion, we have extrapulmonary and intrapulmonary parts. The extrapulmonary part starting from the nasal cavity, pharynx, larynx, trachea, and main bronchi. The intrapulmonary portion starting from the intrapulmonary bronchi, bronchioles, and terminal bronchioles. The respiratory portion, we have three parts: respiratory bronchiole, alveolar ducts, and alveolar sacs. These three parts together called respiratory acini. We will take the diseases of nasal cavity, pharynx, and larynx today. This diagram shows the different portions of the respiratory system, starting from the nasal cavity down to the main bronchi. Here we have the extrapulmonary conducting portion, trachea and main bronchi, and then we will move to the intrapulmonary conducting portion from the main bronchi down to the terminal bronchioles. And inside this circle, the respiratory portion, we have respiratory bronchiole, alveolar duct, and alveoli. Inside these alveoli, the gas exchange occur. We will start the diseases of the upper respiratory tract. The diseases of the nose and paranasal sinuses. We have two different diseases, inflammatory and neoplastic. The inflammatory, we have acute and chronic inflammatory lesions. The causes of acute inflammatory reaction, including viral, bacterial, and allergic. The chronic inflammation could be specific or non-specific. The specific like TB, syphilis, leprosy, fungal, and scleroma. We already had it in general pathology. The chronic non-specific inflammation in the nasal cavity, we call it chronic hypertrophic rhinitis or allergic nasal polyp. Acute rhinitis or common cold, sinusitis, and pharyngitis. This is a very common disease caused by a different type of viruses. Rhinoviruses and coronaviruses cause about 50% of common cold, but other type of viruses has been implicated as respiratory syncytial virus, para-influenza virus, adenovirus, and sometimes group A beta hemolytic streptococci can cause acute rhinitis, sinusitis, or pharyngitis. What are the symptoms of this disease? Mainly rhinorrhea or discharge from the nasal cavity, nasal obstruction, and sneezing. The discharge starts as watery and then becomes thick and purulent with or without low-grade fever. The prognosis of this disease, usually mild and self-limiting, can be complicated by bacterial infection. The gross picture of the mucosa in case of acute rhinitis, the mucosa is usually edematous, red, and congested. The microscopic picture, the mucosa is infiltrated by different types of inflammatory cells like neutrophils, lymphocytes, and plasma cells, with scattered, congestive, dilated blood vessels and separated by edematous stroma. Allergic rhinitis, it is type 1 hypersensitivity reaction. It is an immediate tissue response to antigen after the interaction with immunoglobulin E antibody previously bound to the surface of mast cells. It occurs in a sensitized, susceptible person. After repeated attacks of allergic inflammation, results in chronic changes in the nasal mucosa. The nasal mucosa becomes hypertrophic, thickened, and polypoid, causing formation of allergic nasal polyp. The gross picture of these polypi are soft, glistening, semi-translucent, extend laterally from the mucosa and obstructing the lumen of the nasal cavity. The microscopic picture of the nasal polyp. This is the lining, the nasal epithelium or the respiratory epithelium. And this is the lamina propria or the underlying stroma, which infiltrated by different inflammatory cells, mainly eosinophils here. And here we have the respiratory epithelium and the inflammatory cells in the underlying stroma, scattered, dilated, congested blood vessels. This is a 50-year-old male patient suffered from obstructing nasal mass for 10 months. Excisional biopsy of this mass or nodules was done and revealed infiltration by histiocytes, lymphocytes, plasma cells, together with areas of fibrosis. Most of the histiocytes had abundant clear cytoplasm. The microscopic picture of the case, we have here the ulcerated respiratory epithelium, and the underlying stroma showed aggregates of foamy histiocytes admixed with scattered Russell bodies. So we have aggregates of muculic cells and Russell bodies. So the diagnosis is rhinoscleroma. We finished the diseases of the nose, and we will start the diseases of the tonsil. This is the normal tonsil. This low power of microscopic picture of tonsil covered by epithelium and with underlying scattered variable sized lymphoid follicles. This is H&E stained slide. Shows a covering epithelium, and this is the tonsillar crypt, and here we have the tonsillar lymphoid follicles of different sizes. Acute tonsillitis or acute inflammation of the tonsil. The clinical picture, the patient suffered from sore throat, يعني بيكون عنده pain in the throat. dysphagia يعني بيبقى عنده صعوبة في البلع. fever, chills يعني عنده رعشة. headache صداع. enlarged painful cervical lymph nodes. هيكون عنده lymph nodes في النك بتكون كبيرة و painful. الكومبليكيشن في حالة الأكيوت تونسيلايتس ممكن تتحول لكرونيك تونسيلايتس لو ما تعالجش. ممكن يحصل spread of infection to the nearby tissue like the ear، فهيحصل otitis media or in the peritonsillar area leading to formation of abscess. ممكن يحصل post streptococcal complication زي الروماتيك فيفر أو الأكيوت post streptococcal glomerulonephritis. Case 2, a 9-year-old boy presented with fever, chills, sore throat, and dysphagia. On examination, both tonsils were markedly enlarged with red, multiple yellow spots. Here is a picture of acute tonsillitis with enlarged tonsil and different crypts filled with pus. يبقى هنلاقي التونسلز هنا على الناحيتين enlarged و congested و covered by pus، والpus بيبقى accumulated في ال tonsillar crypts. So this is example of acute follicular tonsillitis. Case 3, an 11-year-old boy presented with fever, chills, sore throat, and dysphagia. On examination, a peritonsillar mass was seen with deviation of the uvula to one side. Here is the mass with deviation of the tonsil to one side. This picture showed a peritonsillar mass or abscess. We call it quinsy or peritonsillar abscess. This is a complication of tonsillitis, acute tonsillitis. We will start another topic, which is diphtheria. The diphtheria caused by Corynebacterium diphtheria. Less common لأنه في دلوقتي immunization against diphtheria فبدأ يقل incidence of diphtheria. The pathogenesis احنا عارفينها من الجنرال. البكتيريا اللي هي الكورينيبكتيريوم ديفتيريا دي بيحصل لها ان هي بتimplant على الميوكوزا وبتعمل secretion of exotoxin leading to necrosis of the epithelium with abundant fibrinopurulent exudate. النكروتيك epithelium مع الاكسوديت هيكون لي pseudo membrane. Complication of diphtheria ممكن يحصل suffocation due to extensive edema or detachment of a part of the membrane leading to obstruction of the airway. ممكن يحصل absorption of the exotoxin leading to injurious effects as myocarditis, focal myocardial necrosis, and polymyalgia. Case 4, a 6-year-old girl presented with fever, chills, sore throat, with difficulty in breathing. On examination, the whole throat was markedly swollen and covered by dirty gray membrane. This is the membrane here involving the uvula and both tonsils. So the diagnosis here is diphtheria. Diphtheria affecting the tonsils and uvula. The nasopharyngeal carcinoma occur in the area of the nasopharynx. What is the etiology and what are the presenting symptoms and different histologic types? Epstein-Barr viruses and genetic susceptibility are considered the most important etiologic factors of nasopharyngeal carcinoma. The presenting symptoms, the tumor usually start as a small undetected or hidden tumor and spread to the cervical lymph nodes. We have 3 different histologic variants, the keratinizing squamous cell carcinoma, non-keratinizing squamous cell carcinoma, and undifferentiated carcinoma, formed of large epithelial cells with vesicular nuclei and prominent nucleoli, admixed with dense small lymphocytes. Case 5, a male patient, 50-year-old, had a repeated ear infection. On examination, a mass was seen in the nasopharyngeal area. Biopsy was taken And this is the microscopic picture of this biopsy, consisting of or showing two different cell types. Here are the epithelial cells and the small lymphocytes in between. The high power showed large epithelial cells with scattered mitotic figures and a few multinucleated cells, and intermingled with small lymphocytes. So this is undifferentiated carcinoma of the nasopharynx, and we have another name of this undifferentiated carcinoma. We call it lymphoepithelioma because it consists of two cell types, epithelial cells and lymphocytes, so we call it lymphoepithelium. We will move to the larynx, and we will start by the laryngeal nodule. This nodule usually occur in school teachers or in singers due to abuse of voice. These patients usually complained of hoarseness of voice. On examination of the larynx, there is a hemispherical small mass about ½ centimeter diameter on one of the vocal cord with smooth surface. Here is a laryngeal nodule, or we call it singer's nodule because it occurs in singers due to زي ما قلنا abuse of voice. Another picture of laryngeal nodule. The microscopic picture showing the covering epithelium and the underlying stroma. This stroma is edematous, loose, fibrous stroma with scattered blood vessels. Later on, the stroma become hyalinized like this. The tumors of the larynx are classified into benign and malignant. The benign could be epithelial origin or mesenchymal origin. The epithelial benign tumor, we call it a squamous cell papilloma, and we have different types of the mesenchymal benign tumors like fibroma, hemangioma, chondroma, leiomyoma, and lipoma. All these tumors are rare. The malignant tumors of the larynx also divided into epithelial or mesenchymal origin. The epithelial malignant tumors of the larynx, the most common is the squamous cell carcinoma. The other tumors including adenoid cystic carcinoma, mucoepidermoid carcinoma, and also the rare mesenchymal malignant tumors, angiosarcoma, liposarcoma, chondrosarcoma, and leiomyosarcoma. We will start by the benign epithelial tumor of the larynx, squamous cell papilloma. We have two types of the squamous cell papilloma according to the age. We have the juvenile laryngeal papilloma and adult laryngeal papilloma. Juvenile laryngeal papilloma occur in children and adolescents. The adult occur in adult and more common in male. The juvenile usually multiple arising from the two vocal cords, while the adult usually solitary. The juvenile extend to the false cords and epiglottis and subepiglottic area. The adult doesn't extend. The juvenile usually recurs and caused by human papilloma virus. The adult type recurs less frequently. Both produce hoarseness of voice and may become alterated due to trauma, leading to hemoptysis. Case 7. Over the last 3 months, an 8-year-old boy had difficulty in breathing with changing in the character of his voice. On examination, multiple finely mammillated masses were seen on the vocal cords. Here are the masses. The outer surface of these masses was finally mammillated like the raspberry, so we call it raspberry-like appearance. Microscopic picture of these masses showed finger-like polypoid branched core of connective tissue covered by orderly arranged stratified squamous epithelium showing acanthosis papillomatosis, and hyperkeratosis. So what is your diagnosis? The diagnosis is squamous cell papilloma. This is a microscopic picture of the squamous cell papilloma. This is the core, the connective tissue core, covered by squamous epithelium, finger-like, with acanthosis, papillomatosis, and parakeratosis. Squamous cell carcinoma of the larynx. What are the precancerous factors in laryngeal carcinoma? These factors are smoking, alcohol, asbestos exposure, Epstein-Barr virus infection, and previous irradiation. Very rare carcinoma can occur on top of squamous cell papilloma, chronic laryngitis, and abuse of voice. Clinically, the patient usually complains of persistent hoarseness of voice. Squamous cell carcinoma of the larynx can start as carcinoma in situ, appears as pearly gray wrinkled plaques that grow to form a nodule. Then the nodule form a large fungating mass, can be ulcerated or infiltrating the underlying wall. This is another example of squamous cell carcinoma of the larynx infiltrating the epiglottis. The microscopic picture of the squamous cell carcinoma, like other squamous cell carcinoma in the body. This is a low power, showing the normal squamous epithelium, and this is the ulcerated part lined by malignant squamous cells. The squamous cell carcinoma can be divided into well-differentiated, moderately differentiated, and poorly differentiated according to the keratin formation, nuclear polymorphism, and mitotic figures. We have here a high power showing scattered groups of malignant squamous cells with central keratinization. Another case of squamous cell carcinoma showing the malignant epithelial cells with central keratinization. And this is the high power, more high power, showing scattered mitotic figures, polymorphic nuclei, prominent nucleoli, and the intercellular bridges between the neoplastic squamous cells. Types of laryngeal carcinoma. We have three types. The first and the most common type is the glottic type. Accounts about 60 to 70% or 75% of the cases arise directly from the true vocal cords, usually well to moderately differentiated, so it has a better prognosis. The mass arise from the true vocal cord, so interfere with the mobility of these cords, so the patient symptomize early. The true vocal cord have sparse or no lymphatics, so no or little lymph node metastasis can occur in these cases. The second part is the supraglottic type, accounts 30 to 35% of the cases. We call it extrinsic tumors. It arises above the level of the true vocal cords. This area is rich in lymphatics. So the spread is very early. Nearly about 1/3 of the tumors metastasize to the cervical lymph nodes. The third type is the infraglottic type. About 5% only of the cases tend to remain clinically quiescent, symptomize very late, and present as advanced disease. It usually high grade and high stage. The first type, which is the glottic type, have a better prognosis because of low grade, early symptoms, no or little lymph node metastasis. This diagram shows the three different types of laryngeal carcinoma: supraglottic, glottic, and infraglottic. This red spot on the true vocal cord, at this area arise the glottic carcinoma. We call it intrinsic. Above this area, the supraglottic, and below this area, the infraglottic. Case 9, a 70-year-old man complained of persistent hoarseness of voice. For the last 6 months on examination, there was an enlarged, non-tender, non-painful anterior cervical lymph node. Laryngoscopy revealed an irregular fungating ulcerating large mass. At the supraglottic area. Biopsy was taken, and this is the microscopic picture of the lesion. So the diagnosis is squamous cell carcinoma of the supraglottic laryngeal area. The complication of laryngeal carcinoma, local complication, the mass can ulcerate, infection can occur, hemorrhage and obstruction also can occur. Infection of the distal respiratory passages like lung abscess and bronchopneumonia can also occur as a complication of laryngeal carcinoma. Metastasis via lymphatics or blood vessels can occur. More common in the supra and infraglottic, and we know the causes now. Also cancer cachexia, which is the weakness, wasting or loss of weight, and anemia. The treatment of laryngeal carcinoma, these patients treated with surgery, radiation, or combined therapeutic treatments. Many patients can be cured with these different type of treatment. Thank you.